Good evening, everyone, and welcome to our webinar. We have got a full house tonight, so thank you for joining us. If you don't know me, my name is Celeste Jordan. I'm the marketing manager at Wright Milners, and I'll be your host this evening. The order of tonight's proceedings will be as follows. Dr. Rocio will present. After that will be a question and answer session, so please feel free to ask your questions in the panel on the right-hand side. After the Q&A, I will share our launch promotions on RivaStar and Riva Glass Enamel. I would like to take this opportunity to say thank you to Michael Farrow from SDI for sponsoring our event tonight. The focus of tonight's presentation is twofold. The opportunity to do more non-aerosol generating procedures in these COVID times. And number two, to take a look at new technologies to help improve practice profitability. I would like to introduce you to Dr. Rocio Lazo from Peru, although she's joining us from Spain this evening. I had the pleasure of meeting Dr. Rocio about 2 months ago, and what really struck me about her is how passionate she is about the research and the work she's doing in pediatric dentistry. So Dr. Rocio, over to you.
Thank you. Thank you, Celeste, for introducing me. And good night to everybody. I'm so glad to be invited for you, Celeste, and from SDI to talk to us this night. So I will share the presentation. Great.
I can see the full presentation, Doctor.
Perfect. Do you want to introduce more, Celeste, or it's okay? I can start?
You can start. Thank you, Doctor.
Okay, I will start. So, okay, today we are going to talk about minimally invasive dentistry. Today, if we are talking about the virus, the COVID-19, we are thinking that for prevention, we suggest to don't use aerosols. So if you're thinking in no use aerosols, what is the technique that is most effective? Will be minimal invasive dentistry. So right now, I will talk about the efficacy of modified bioactive glass for bioremineralization upon tension the effect of silver diamond fluoride. And I will talk about the technique that's called SMART. Okay, so I will introduce. I am pediatric dentistry from Peru, University Peruana Cayetano Heredia. I am professor of postdoctoral pediatric dentistry program at Científica del Sur University in Peru. I am clinical director by Special Smiles. I did an internship in pediatric dentistry in University of California, San Francisco. I have 3 awards about research, silver diamond fluoride, and another 2 research in pediatric dentistry about minimal invasive dentistry. And I am invited for a lecture in the Royal Academy of Medicine and Relative of Science. This is a little part of my life profession. And I am from Peru. Celeste introduced Me said that I'm from Peru. Peru, it's a beautiful, beautiful country. If you want to visit, it's so wonderful. Machu Picchu and Inca culture is amazing. So if you have the opportunity for travel to Peru, you will love it. Okay, what are the topics that we are going to talk tonight? First, we're going to talk what means minimal invasive dentistry. That today you will listen to this no dental aerosols, okay? Then we are going to talk what kind of material work in minimal invasive dentistry. We're going to talk about silver diamond fluoride, SDF, 38% for caries arrest and remineralization. Then I will talk about biomimetic. Biomimetic, it's a new philosophy in dentistry. So I'm going to explain to you what means biomimetic and what are the biomimetic materials. One of the biomimetic biomaterials are the bioactive glass. And if we are talking about bioactive glass, we will talk about the new glass ionomers that are the strontium modified bioactive glass. So these kind of materials will increase the bioremineralization in dental caries and molar incisor hypomineralization. And we finish talking about smart technique. So smart technique, okay, we're going to talk about the mix of SDF and a modified bioactive glass. Okay, so these are the topics that we are going to talk tonight. And I love to say before this presentation this phrase that knowledge is powder. Why? Why is so important? Because if we know that what happened histology in caries, in enamel, and in dentin, and what happened in hypomineralization molar incisor, we are going to find the perfect material for minimal invasive dentistry. So this is important to know the histology, to know what is the better option for this kind of treatment. Okay, so we are going to talk first about the philosophy of minimal invasive dentistry. Minimal invasive dentistry, no, you are listening more in this year because it's prevention for COVID-19. Why? No drills. Suggest no drills, for minimal invasive dentistry. Why no drills? Because if we want to prevention dissemination of the virus, okay, no, don't use aerosols, okay? So the transmission you will control in your dental practice if you don't use aerosols, okay? If you're using aerosols, you need to use a face shields and some protection, for aerosols. But right now, with minimal invasive dentistry, you don't need to be afraid about aerosols. But minimal invasive dentistry philosophy, it's not only this no aerosols, it's more. First is detection of early caries lesion. Second, prevention and the risk of your patients. Then is the minimal intervention, arrest caries, and remineralization. So this is the philosophy, the real philosophy of minimal invasive dentistry. It's so important that the diagnostic, detection, the early caries lesion, especially in patent fissures, Sometimes it's so important to use magnification for look better, if these patent fissures are sounds or are desmineralizations. We are going to look in these pictures, these lesions And you look, these lesions are in enamel, impedant fissures. Okay, we can do minimal invasive dentistry here. Yes, it's a perfect case. What another case is perfect for minimal invasive dentistry? When we take an X-rays, an Bidewin, no X-rays, and you can look in the X-rays caries in proximal surface, no? In this case, you can do it perfect minimal invasive dentistry. Yeah, look here. This is Bidewin X-rays, and look here. It's not cavity. So how can we do here? What kind of treatment? Minimal invasive dentistry, it's great for this. And if we have in enamel, no, with cavity, we are going to talk about the selective removal of caries tissue, okay? And you don't need to use drills here. No high speedy for selective removal. You only need the dental spoon excavator to remove. Look at this picture. You only need this dental spoon excavation. And if we were talking about caries in dentin, okay, it's easier, no? Because you diagnostic, it's going to be so fast. But the treatment, what is the best treatment for these cases? Select remove of caries tissue. So we need, no, to remove the infective dentin and work in the affected dentin. We are looking the systematics review that said that it's perfect decision if you are doing selective remove in dentin. Okay, so selective remove, you have in the dentin lesions, the infected dentin is soft and the affected dentin is firm. Okay, when you're talking about infective, you're talking about a necrotic zone, contaminate zone, and desmineralization. But if you are talking about affective, it's desmineralization, but it's reversible, okay? So we look here, this is the infective dentin. We need to remove all the infective dentin to have good results in these treatments, okay? If we want to know the difference about affective dentin and infective dentin clinical, look here, the color, both colors are different. One, it's more dark brown, dark brown, and the other is like light brown, okay? So this is the difference of infective and effective. We need to work in the effective dentin because it's a bio-friendly tissue. Perfect tissue, okay? So what happened? What happened in this affective dentin? This affective dentin, it's the histologic characteristics are so similar than the sound dentin. One of the only different is the affective dentin has more organic matrix, okay? And the sounds not. So the affective dentin, it's so important because it's rich in organic matrix. And this will be great for us, no? Because it's going to be better for remineralization, no? This reversible desmineralization, and we are going to have a good remineralization. So what's the problem? The problem is not the remineralization. The problem is the material that I will use in this affective dentin. So often we have the decision to use it adhesive materials as glass ionomers or resins. But in these cases, the adhesion is not good. The technique ART, the atraumatic restorative treatment, are from the 80s, had a lot of time ago. And we are going to check this review, this systematic review, that it's about 21 years, no? Follow up about ART and looks the results of ART. If you look in here, it's the percent, it's 24 to 96. And for primary teeth, it's 43 to 98. It's so different, okay? You have 43 or 98. So what is important to have a better result? Not the 48. I want to have the 98% of successful in my treatments. So what I need? First, glass ionomers are always the material of choice in ART technique. But why the classic glass ionomers doesn't have the 100 successful? Why don't have it? Okay, remember, if we are talking about enamel, the hydroxyapatite is 97%. And if we are talking about dentin, is the 70% of hydroxyapatite. So this is hydroxyapatite. It's formed from calciums and phosphate. What happens when we have an acid attack? Okay, acid that's come from the plague or from the food. Okay, we're going to lose calcium ions and phosphate ions. We are going to lose these hydroxyapatite crystals. And what is going to happen when we lose? We are going to have desmineralization. Desmineralization will happen if you lose calcium ions or phosphate ions. And what is the best remineralization material? If we have this losing calcium and phosphate, and we want to have again a hydroxyapatite crystal, we are going to ask for what kind of material? We're going to ask to the fluoride for remineralization. But what needs this fluoride to fluorapatite formation? Needs calcium and phosphate. If you have fluoride ion and you don't have calcium, you are not going to have remineralization. Remineralization is not the fluoride. Remineralization is the fluorapatite formation. This is remineralization. And what needs the glass ionomers in dentin to have 100% successful in our treatment? First thing, we need to have good accounts of calcium. But remember, effective dentin has more organic matrix than inorganic matrix, okay? So the accounts of calcium are not going to be so high. The second thing, glass ionomers need interaction of ion fluoride and ion calcium for remineralization. And of course, to form fluorapatite crystals. That needs glass ionomers. Not all the time you will have good accounts of calcium and this good interaction of ions, fluoride, and calcium. And this is the reason then sometimes you have good results when you are using glass ionomers, and in another case, you don't have good results. These things will depending in what kind of dentin you are working. If you are working in an effective dentin or in a sound dentin. If you want to do it minimal invasive dentistry, you will work in an effective dentin. And if you are going to work in an effective dentin, knows that it's not have good accounts of calcium. So that's makes to you to think about what is the good alternative of materials for effective dentin. What happened with resin? Because you said, okay, maybe glass ionomers are not good option. And what happened with resins? The problem with resins and a bad adhesion in the effective dentin is because we have present the matrix of metalloproteinase. The metalloproteinase are sleeping in the dentin. And when you are using the orthophosphoric acid, you are going to wake up again the matrix of metalloproteinases. And these metalloproteinases will be eating this adhesive, so you're not going to have good adhesion. Look here, okay? Here is a resin in an effective dentin. I apply a resin in an effective dentin, and look here. What happened? Okay, metalloproteinases wake up because I'm using maybe orthophosphoric acid, okay? And this orthophosphoric acid wake up these metalloproteinases, so we are not going to have a good adhesion, and we'll have a secondary caries. Look here. This research, no, it's agree with I am talking, no? This doctor Ricucci said, okay, I think that minimal invasive dentistry, removing the effective dentin, will not going to have good results. But why Dr. Ricucci are thinking that you are not going to have good results with this kind of treatment? Why? Because in this research are using resins in an effective dentin. And remember, what happened in the effective dentin when you're using resins? Okay, the orthophosphoric acid will be wake up metalloproteinases, and these metalloproteinases, we're going to have problems with the adhesion, okay? And of course, secondary caries. So what is the message here? My suggestion is no resin fillings in an effective dentin, okay? Right now, this is the new challenge in our practice, the hypomineralization, okay? The molar incisor hypomineralization that are coming so often to our dental office. And the patient said, oh, I have problems with the aesthetic. I have problems that the color, it looks like yellow, brown. And if you are looking this kind of case, you said, what I'm going to do? Because molar incisor hypomineralization, it's a headache for dentists. First, because this patient wants aesthetic. Second, the enamel of this lesion, it's don't have good counts of calcium. So it's often that have micro fractures in the enamel, no? So it's going to broken so often this enamel. And then the patient will present hypersensitivity and the adhesion, it's not going to be good. Why? Because we don't have good accounts of calcium. So let's check. This hypomineralization has enamel deficient in minerals the 20 to 25%. Okay, so you will have a risk in this lesion to have caries around the lesion, the molar incisor hypomineralization. The other thing is that in dentin, you will have more zones of interglobular dentin. Interglobular dentin is slightly less mineralized. So check it, okay? It's important to know the histology about this. So if you are going to know that if you get the decision to use glass iomer in hypomineralization, no, in molar incisor hypomineralization, you may be going to have some failures. Why? Because you don't have good accounts of calcium. And what needs the fluoride? The fluoride needs the calcium to fluorapatite formation. This is the problem. This is the problem. It's the same problem that we have in dentin. It's the same problem that we have here in enamel, but in enamel, in molar incisor hypomineralization. Okay? So, what kind of materials? What kind of materials are great for minimal invasive dentistry? The materials that are great for minimal invasive dentistry is SDF and bioactive biomaterials. So why SDF is great for minimal invasive dentistry? Because with SDF, we're going to have minimal intervention, caries arrest, and remineralization. One another material, it's great, the bioactive biomaterials. And the bioactive biomaterials, we have right now this new generation of glass ionomers that are the strontium modified bioactive glasses. This kind of material is great for minimal invasive dentistry. And why it's great for minimal invasive dentistry? Because first, minimal intervention, arrest caries, remineralization, and bioremineralization. So it's great. And smart technique. What means a smart technique? Smart technique is the silver modified atraumatic restorative treatment. So we're going to use first SDF 38%, and then we apply a bioactive biomaterial that is the modified, the strontium modified bioactive glass. With both kind of materials, we are going to do the smart technique that I will explain later. So, talking like this introduce about what is the best option for materials in minimal invasive dentistry, we are talking about SDF and bioactive biomaterials. Okay, I will talk right now about SDF 38% and Ki, that is the potassium iodate. Okay, this material is not new. You are maybe listened in the last years so much about SDF, but SDF is not a new material. This material are working before the 80s, so much in countries like Japan, Brazil, and Argentina, okay, and have good results. But we are start listen about SDF because FDA approved the SDF in USA the 2015. And I participate in this research, no, that have the Hipólito Unane Award, no, because this research helped to the FDI to introduce in USA and approve the SDF. So this study that I participate, it was in permanent teeth, and we talk about the sensitivity of good desensitization of silver of SDF. Okay, what is the composition of silver SDF, silver diamond fluoride? First, silver ions. Second, amine and fluoride. Here is the composition. And if we compare the SDF with the fluoride varnish, look the difference in fluoride accounts. One, it's 44,800 ppm, and the fluor varnish, it's 16,000 of ppm. So it's maybe double accounts if you compare SDF with the fluor varnish. And the Academy of Dental, the American Dental Academy, suggests that the best material for non-restorative treatment is SDF, okay? And if you're thinking in patients that are receive radiotherapy or chemotherapy, a great option for control caries is SDF. Okay, so this is no restorative cavity problem control. If we are looking this picture, in this case, look this first primary molar with a caries lesion in enamel. So we took the decision to use SDF 38%. Okay, we use it, we apply in this enamel lesions, and after 2 months of follow-up, look here the results. Perfect remineralization. Why we have a perfect remineralization? Because SDF has a good penetration in enamel. The penetration is 50 micrometers. Okay, so you will have a great result with SDF. The penetration is so good in that interprismatic space. But what is the problem with SDF sometimes? The color, okay? So the color is the problem, no? But if your problem is the color, that it's a dark color staining the lesion, okay? You can use the Ki, the potassium iodide, that it's great for control these dark colors. Okay, look here. This is a treatment in enamel caries in pit and fissure. Okay, we first apply the SDF, and then we add the Ki. And look the color. The color is not so dark. It's like a light brown. And another good thing is that if you are applying the SDF with the Ki in some pit and fissure, you are not going to have problems with the staining. Look here, no problem with the staining. It will be a staining only if you have caries. If you don't have caries, if it's a sound pit and fissure, it's not going to have any problem with the staining. And in dentin, okay, this is what it's going to happen, like a light brown, okay, it's if you use it, the Ki. So it's a great option for prevention. For example, pit and fissure sealants with SDF will be a great option. And in the case that you have early caries lesions in pit and fissure, okay, better than use it a resin sealant, it's better if you use a SDF. And what happened in proximal surface caries? Okay, let's look in this X-rays, you have here both caries. In distal, it's a dentin caries, but here in mesial, it's an enamel caries. Okay, and we took the decision to use it SDF in this enamel caries. Okay, after 6 months of follow-up, look here, remineralization. The surface is remineralization. If you compare with the X-rays, that it's the preoperative, and look the follow-up 6 months, you compare, so it's remineralization. You have great results. So it's good, and it's a suggestion for better results in proximal lesions, like this case. Use our orthodontic separators. If you use an orthodontic separators, look, you will check better if you have an enamel caries cavity or not. Okay, and when you apply the SDF, will be easier, no? Because you maybe can use this Oral-B flow that, okay, you can put the SDF in the floss, and you will introduce the SDF in this proximal surface with have good results. Okay, and if you want, you can use it these points. No, these points are perfect for proximal lesions. To apply the SDF and then applies the Chi. Look here, good results. And what happened? What happened in dentin? I show us about enamel lesions, but what about no restorative cavity control in dentin? Okay, let's check it. Look here. Caries in enamel, we decide to use SDF. So follow up 12 months. We compare the X-rays of preoperative with the X-rays follow up 12 months, and we look at remineralization. Here is remineralization of the lesion in dentin and enamel. So you will have good results too, because the penetration in dentin, it's so high, 50 to 200 micrometers. So it will place great. Do you remember that I talked to us about the metalloproteinas? So we have problems with the resin, with the adhesion. Okay. So the matrix of metalloproteinases will, if you will use the SDF, you are going to inhibition the activity. You are not going to wake up this matrix of metalloproteinas. So you will get good results. Great for remineralization, great in penetration. So if we are talking in rest, caries, and remineralization in dentists, SDF, it's a good option, okay? Don't worry about the color if you use the Chi. This is case that we have caries in dentin. You first applies the SDF, and then we apply the Chi, and you will have great results. Okay, what is a SMART technique? SMART technique, it's silver modified atraumatic restorative treatment. So this will mix, okay? In this case, for example, we decide to apply first the SDF and then close the cavity with glass iomer, okay? And we have here this to compare the upper and the lower. In the upper, I decide to use the Chi for the color, not staining. And in the lower, I only use SDF. So if you compare the looking, no, it's better in when we use the Chi-I than when don't use it the Chi-I. If we check both upper and down and lower, no, both great results, remineralization, 80 months follow-up, great results. Okay, so it's an option, a good option to use a smart technique in dentin. No, if you want to be so sure to close the cavity, it's a good option, the smart technique. But the smart technique is not only with glass ionomer. You can have a smart technique using a resin. But I suggest that it's better for dentin glass ionomers. And for enamel, think to apply resin. Okay? So we have here this early caries lesion in enamel. So we decide to apply first, no, the SDF, and after applies the SDF, I add the Chi-I. The Chi-I applies, and then if I want to apply the flow resin, the perfect option of adhesive is the universal adhesive. And who is a universal adhesive? Zip bond. Why? Why is it good? Because this universal adhesive has MDP, that it's a good for mixed with calcium and fluoride. And this universal adhesive has fluoride too. So we'll have good results. Okay? Look, the follow-up of 6 months, perfect. The treatment, this is a smart technique with resin. I suggest this smart technique with resin for enamel and for dentin with glass ionomers. Okay, so we are talking that the penetration, it's great in SDF. It's so great. But we have to be so careful because the penetration, it's so good. But if you work with the SDF so close to the pulp, maybe you will necrotic the pulp, like this case. Look here. I am using here only an SDF. This is the SDF that I use it here is Advantage Arrest that don't have the Chi-I. It's only SDF. And then I apply the glass ionomers. And after 4 months follow up, look here, an abscess. When I open the pulp chamber, look here, the penetration of the silver, it's so good. But it's so good that the penetration, it's here in the pulp chamber. And that is the reason that this molar is necrotic. Okay, the pulp is necrotic. So use SDF so close to the pulp is not a good option. Okay, be so careful. I prefer to use SDF if we are looking in our dentin, the middle, no? The middle, you use it, the middle that it's to the occlusal zone, you can use it SDF. But if you are in the middle, close to the pulp, it's preferred to don't use SDF because you are going to have the risk of necrotic the pulp. So what kind of material, if we are going to be close to the pulp, it's great. If the problem of the SDF is the penetration and you will necrotic this pulp, what is the good option? The good option is to use a biomimetic material. And what means biomimetic? Biomimetic means to copy or mimic the nature. And what will I mimic? I will mimic the bioremineralization. And what means bioremineralization? When we are talking about the development of the tissues, these mineral tissues like the bones, enamel, or dentin, okay, these are mineralized tissue to development first needs a organic matrix, okay? These organic matrix are going to crystals the ions calcium and the ions phosphate, okay? So the cells that are going to form, for example, in enamel are ameloblasts, and in a dentin are odontoblasts. Odontoblasts are going to produce ions calcium and ions phosphate. So these ions are going, okay, to be crystal in the organic matrix, and it's crystal to hydroxyapatite formation. So you need for this remineralization, for this mineralization material, you need our organic matrix to have great results. Okay? So what is going to mimic the biomimetics or the bioactive biomaterials are going to mimic the bioremineralization. Okay? And this is so important because, for example, do you remember that I talk about the affective dentin, that the affective dentin has more organic matrix than the sound dentin? Do you remember that? Of course. So for this, biomimetic materials are going to play a good role. It's going to work perfect for bioremineralization. Okay, we are going to talk about the first bioactive biomaterial, the first bioglass. It's development for Dr. Larry Hinch in 1969, and I will Dr. Larry Hinch, okay, development this kind of bioactive glass for bones, okay, for large bones to stimulate the bioremineralization. So I will show to you this video.
Human beings are fragile. Accidents, injuries, traumas. The human body can regenerate itself, but sometimes it's not enough. Implants, prostheses, and substitutes are often necessary to rebuild osseous structures and help the body to regain its functionality. Bioactive glass contributes to bone growth. It can be used in a wide range of medical applications. Like here, in the case of bone filling, the material is put into the bony defect. Just a few hours after the implantation, ionic exchanges occur between body fluids and bioactive glass. A biological fixation is created between the biomaterial and host tissues, leading to a solid grip within the osseous site. This fixation becomes a silica gel and gradually mineralizes into a calcium phosphate layer. The composition and structure of this layer are identical to human bone. The fact that silica and phosphate concentrations are increased around the material causes a genetic activation, which induces a differentiation and proliferation of osteoblasts. These osteoblasts are the actors of bone remodeling. glass, its bioactivity lies in its ability to transform itself, and in the end, to become completely assimilated by hosts. Hosts, or rather, human beings.
So we looked at this bioactive glass works perfect for biomimetic, for bioremineralization. And what means bioactivity? Bioactivity is to stimulate or regeneration in generate of the material tissue interface. Okay, so let's check. These bioactive glass are used, for Dr. Larry since 1969, and for dentists will be great these biomimetic materials, but it's starting right now to use it. I am talking about biomimetic for 10 years. I used all kind of biomimetic biomaterials, and it's perfect for minimal invasive dentistry, the bioactive glass. So how works this bioactive glass? This bioactive glass, we need to remember the development of the enamel, okay? The enamel, it's formed for prints. The prints are formed from crystal, hydroxyapatite crystals, and these crystals are formed for calcium and phosphate, okay? So what happened? We have the cell, this ameloblast, okay? So ameloblasts are going to be cubed, and then we are going to form a principal protein that's called amelogenin. So the ameloblasts are going to form to produce iron, calcium, and phosphate, and amelogenins are going to regulation these ions and transportation to the organic matrix. And what happened in the organic matrix? Remember, these ions will going to crystallization for hydroxyapatite formation, for these hydroxyapatite crystals to mineralize this tissue, okay? So when we have this mineralization tissue, then what happens? Ameloblasts are going to degradation the amelogenins, and we are going to have only a little percent of amelogenins, these proteins that are the organic, the organic matrix of enamel, and it's only 1.5% or 2% if we compare with the 97% of hydroxyapatite. Where are present these amelogenins? These amelogenins are present in the interprismatic zone, okay? And they will be there. So if we are thinking in bioremineralization, amelogenins will play a great role for bioremineralization, okay? But what happened in dentin? It's different because in dentin, the cell that development the dentin, it's the odontoblast, okay? And the odontoblast will live all the life, okay? It's not like ameloblast. The odontoblast will give all the life. And we are going to have in the dentin 70% of inorganic matrix and 30% of organic matrix, okay? So that will be great because remember the organic matrix we need for bioremineralization, okay? And we need organic matrix, and we need a bioactive regulatory molecules that are proteins, and we have a lot of proteins in the dentin. In enamel, we have only amelogenins, and in the case of the dentin, we have a lot of proteins. So here, bioremineralization will be great, okay? So if we are thinking that biomimetic mimic biomineralization, what kind of materials are bioactive? Okay, this is all the family of bioactive biomaterials. We have nanohydroxyapatite, enamel proteins, and bioactive glass. Today, I will talk about bioactive glass. Okay, the bioactive glass, you listen so much about MTA, these bioactive tricalcium silicate cements. They are great for treatments in pulp therapy. Okay, this bioactive glass need hydration. Okay, the first bioactive glass for dentists is the MTA, and it's approved for FDA in the 1998. Okay, so how works this bioactive glass? Look here. This is collagenous fibers. This is our organic matrix of the dentin. Okay, so here we have the bioactive glass is in the organic matrix in the affective dentin, okay? And in that moment, this bioactive glass, we're going to start, to throw away calcium ions, a lot of calcium ions, a lot. And what happens if you have a lot calcium ions? How it's going to happen with the pH of the zone? The pH of the zone will be more alkaline, and this is good for inhibition of bacterial growth. And what happened more? Okay, we have a lot counts of calcium right now, but at the same time, this calcium will active the proteins. This is the proteins, okay? And what happened with the proteins of the dentin? The proteins are going to wake up the odontoblasts, and these odontoblasts are going to produce again calcium and phosphates, and the proteins will carry these calcium and phosphate ions to the matrix, to the organic matrix that have the affective dentin, and we will bioremineralization. So this will be great. Affective dentin is a great tissue for bioremineralization because we have a organic matrix more than in a sound dentin. So in this affective dentin, we can use this bioactive glass. So we have good accounts of calcium, and this calcium will wake up the proteins, and the proteins were going to wake up the odontoblasts, and the odontoblasts are going to produce again calcium and phosphate. That is going to crystallization in the organic matrix, and you will form the new crystals, okay? The hydroxyapatite new crystals. So it's great to use these bioactive glasses if you are, for example, in caries in dentin, so close to the pulp or to the pulp. Look here, this is the bioremineralization. It's a great bioremineralization in the intertubular dentin. So let's check this case, okay? Look, this second primary molar, and maybe if you are thinking, what was the pulp diagnostic? You can tell me, okay, this is a reversible pulpitis. No, the diagnostic in this case is necrotic. Look here, this internal reabsorption zone, okay? And I don't want to do an extraction because we didn't have the first permanent molar. So the perfect the perfect is to still there the second primary molar, okay? So for this treatment, we have the decision to use the bioactive glass, okay? And look, this is initial 9 months of contract. Look here, that it's repaired the internal reabsorption, 18 months follow-up. Look this great. And at 24-month follow-up, who is present right now? The first permanent molar. Look here, it's present. And after 30 months of follow-up, perfect. Perfect, perfect, perfect. Still this treatment with bioactive glass. Okay, another action of this bioactive glass is the inhibition of bacterial growth. Okay, and why? Because it's high levels of pH in this zone. Okay, here we have and effective dentin, a lot of counts of bacteria. Okay, so the bioactive glass, we're going to throw away the calcium, and the calcium will elevate the levels of pH. So you will have great results. Okay. I will show you this case with this follow-up of 30 months. Look here, this patient, the diagnostic is necrotic with fistula, and look, this X-rays, this radiolucid zone, okay? So I took the decision to use a bioactive glass. I did the technique that it's called LSTR pulp therapy, and then I close the pulp chamber. I seal in the pulp chamber with the bioactive glass. Okay, so what means LSTR is using the triple paste antibiotic triple paste, that it's metronidazole, ciprofloxacin, and minocycline for sterilization deletion, but the material that will repair the lesion is a bioactive glass. Okay, look here, 6 months follow-up, the lesion, it's repaired. After 80 months, everything looks perfect. It's 100% repaired the necrotic pulp. After 30 months follow-up, okay, everything is working well. The first premolar, it's going to eruption. Good results. And 30-month follow-up, clinical successful. And I decision to, because this molar is start to moving, so I did the extraction. Look here. It's a perfect sealing of the bioactive glass, a great, great sealing of the bioactive glass. Okay, this is another necrotic pulp repair. Look here, another fistula. Look this radiolucid lesion. I decide to use it, the LSTR therapy, this triple antibiotic paste, only for 3-5 days. Then I remove all this antibiotic paste, and I add to this pulp shampoo a bioactive glass. Okay, in this case the bioactive glass was the nail patty, and the nail patty, it's a mix, is a pre-mixed nail MTA. It's perfect. Look here, 1 month of follow-up. If we compare both X-rays, look here, the necrotic zone, the lesion, it's present, and in 1 month it starts the repair, this focal lesion. Look here. Okay, it looks perfect, this repair. But what is the problem of the bioactive glass? The setting time. The setting time is one of the problems. And the second problem of this bioactive glass that are not permanent restorative materials. We need case is a direct book copy. I used the NeoMTA, no, the NeoMTA party for direct bulk capping, and then I restorative with the Rival Light Cure high viscosity, okay? And look here, 1 month follow-up, great results, good sealing. This is a restoration, okay? But look, the problem with this bioactive glass is that it's not a permanent restoration. So thinking in a restoration with the properties of bioactive glass, we have this new generation of glass ionomers. This new generation of glass ionomers are the strontium modified bioactive glass. With this kind of materials, you can restorative definitely your cavity. Okay, remember what needs the glass ionomers for be successful in dentin? Do you remember? We have first, we need good accounts of calcium, interaction of iron fluoride and iron calcium, and form fluorapeptide crystals. Okay, the problem, what happened? That in effective dentin, we don't have good accounts of calcium. That's our problem, okay? But right now, with this new generation of bioactive glass ionomers with strontium, we are not going to have this problem. Why? Because strontium, okay, if you look here, no, is the same characteristics of the calcium. So you can substitute the calcium, no, with strontium, and you will have good results. You will have a strontium hydroxyapatite, okay? So strontium, it's known to upregulate odontoblast and osteoblast, okay? It's also slightly bacterial, okay? And it's better to work in effective dentin because we'll form these crystals, these strontium hydroxyapatites. So this is the idea. The idea is to add to the bioactive glass, add the strontium to have these great results. If we look at this strontium hydroxyapatite are so big, look the tissue, it's so big, these new crystals are so big if you compare with the regular hydroxyapatite crystals, okay? And another thing that happened, okay? Do you remember that the fluoride ion needs the calcium to fluorapatite formation? But what happens if you don't have calcium? You're not going to have fluorapatite formation. Strontium synergies with the fluoride in a great way. So this mix of strontium and fluoride, okay, we give to you, okay, the strontium fluorapatite. So you are not going to need in this effective dentin if you have good or not accounts of calcium, because strontium will substitute this calcium And this strontium, it's going to form the formation of hydroxyapatite, of strontium hydroxyapatite. And when you add fluoride, the fluoride will be so interaction with the strontium, and we form the strontium fluorapatite, that it's great, higher solubility than the hydroxyapatite. It's more strong, and you will have better remineralization and bioremineralization in defective dentin. So it's perfect. It's perfect. It's perfect. So how it's work? I will show you this video.
It is essential that the glass ionomer is placed while it has a glossy surface. The gloss is free polyacid, which is able to penetrate the cavity surfaces to form a strong, hydrolytically stable chemical bond to calcium ions within the dentin and enamel. In addition to chemical adhesion to calcium in the tooth, a fusion bonding process takes place as well. Calcium and phosphate ions from the polyacid-treated dentin and enamel, and strontium and fluoride ions from the unset glass ionomer intermix and precipitate, forming an interface called the interdiffusion zone. This zone is stronger and more acid resistant than either the glass ionomer or the tooth. The combination of the interdiffusion zone and the chemical bonding provides the basis for a strong, stable adhesive interface and creates a bacteria-proof seal for the cavity, best described as a chemically fused seal. The initial penetration of strontium and fluoride ions into the tooth helps remineralize and harden any demineralized dentin, which is covered by glass ionomer cement. Essential to the success of appetite-forming ion containing increased levels of fluoroapatite. Glass ionomer cements therefore create zones of protection for surrounding tooth surfaces.
Okay, where we're going to find this strontium in this new generation of glass ionomers. This new generation of glass ionomers, you will find this strontium in Riva. Riva has an ion glass, okay? And this ion glass will explain to you in this video.
Riva products contain proprietary glass filler called ion glass. SDI ion glass is a radiopaque reactive glass that releases high amounts of phosphate, fluoride, and strontium ions to assist in remineralizing teeth. Immediately following the placement of the glass ionomer, a ferment of chemical activity takes place under the restorative. Available minerals from the dentin mix with the ions released from Riva, creating a free ion exchange that continues until the acid is buffered by the phosphate ions. As the pH rises, the cement restorative sets and the ion exchange slows down. It has been shown that strontium, fluoride, and phosphate ions from the Riva can penetrate a considerable distance into partially demineralized dentin, aiding in its repair.
Okay, so we here have Riva Light Cure High Viscosity, okay? If you have cavities, there are big cavities, I prefer to use the high viscosity because we'll be resist more the occlusion forces. And we're going to have good results for less plaque grow, no? In this strontium modified glass ionomers with resins, okay? And look here, remove the infective dentin, we have the affective dentin, and we apply the Riva Light Cure High Viscosity. Look here, the aesthetic is so great. If you compare the x-rays, good sealing. This is another case. Look here, this molar. Okay. Look, this second molar, the follow-up 24-month using Rival Light Cure High Viscosity with great results. Look here, it's perfect sealing, no secondary caries. It's remineralization and bioremineralization this zone. Look here, it's perfect, perfect the sealing that you will have with this new generation of glass ionomers that have strontium. Okay, what happens if you have lesions that it's in enamel that are cavity but in enamel? I suggest to use it the Rival Light Cure, not the high viscosity, because this is more flow. Okay, and look here, good results with this case. And in hypomineralization, do you remember what is the problem with the molar incisor hypomineralization? That this enamel and dentin don't have good accounts of calcium. And remember, with this kind of glass ionomers, this new generation of strontium modified glass, bioactive glass in this glass ionomers, you don't need to have calcium because the strontium, okay, it's going to play a perfect work. So you're going to substitute this calcium for strontium. So you don't need calcium. You have strontium in these glass ionomers, okay? So for a sealing, a glass ionomer sealing with strontium is Riva Protect. In this case, for example, look here, is the diagnostic is molar incisor hypomineralization, no cavity. I want to have, to do a bioremineralization of this tissue and prevention caries. So a sealings that is Riva Protect, and look the follow-up, perfect in 2 years follow-up. Look the x-rays, everything is working perfect. And in hypermineralization, when you have this hypermineralization, not only in enamel, that you have the cavity in dentin, I prefer to use Rival Light Cure High Viscosity. For example, in this case, look here, I use it here, the Rival Light Cure High Viscosity, because I will have both here. I will have the strontium, okay, that we are going to bioremineralization and remineralization, and the resin and the high viscosity will give to me this resist to the occlusion forces. So it's great, this material. Look here, how is sealing, perfect dissolution, okay? You look perfect, the bioremineralization and the remineralization. This is another suggest. They said, okay, to this strontium modified glass ionomers, what happens if we add dots of silver dots? Okay, do you remember that the silver, it's great because it kills bacteria, and it's great because inhibition the metalloproteinasas, the matrix of metalloproteinasas. So silver works perfect, okay? So we add to these strontium glass ionomers, these silver dots, and look, better results in remineralization in a bioremineralization. So if you want to use this kind of glass ionomers, you have Riva Silver. So Riva Silver, it's great because you have these dots of silver, and I will show you this case, okay? This case that it's failure, the resin, okay? It's failure, look here, the x-rays. Why is failure? Because the metalloproteinasas, it's going to have the problems with that adhesive, no? Because the orthophosphoric acid will wake up the metalloproteinasas, okay? So no, don't use resins in effective dentin. I prefer to use this Riva Silver, okay? But if you're thinking in aesthetic, okay, after I apply the Riva Silver, the next appointment, okay, I remove a little bit of this Riva Silver and then I use a universal adhesive, the zip bond, and I apply the Aura composite. Look here, if you want aesthetic and use resins, it's good if you are close to the pulp. If you are close to the pulp, look in this case, we are close to the pulp. If you're thinking in use a SDF, no, because maybe if you use a SDF, you are going to have the risk of necrotic this pulp. I prefer to use this Aura Silver, and look here, perfect results. Follow up 9 months and great results. And for finish, do you remember the SMART technique that first applies the SDF and then we close the cavity, we seal in the cavity with the glass iomer? So what kind of glass iomers will be great for this case? The strontium modifies glass iomers. Why? Because remember, strontium, it's perfect synergies with the fluoride, and we have fluoride in the SDF. So we were going to have great results. So if you're thinking in using a SMART technique and you want to have great successful, high successful, it's better if you use this strontium modifies glass iomers. For example, in the case of molar incisor hypomineralization, you can use it both. In this case, I use it first the SDF, then I apply Sky Eye to don't have problems with the staining, and then I apply the Riva Light Cure High Viscosity, with good results in adhesion. I'm not going to have problems with adhesion. I will have good adhesion. So, okay, I hope you enjoy this presentation and you start to be a lover in these bioactive biomaterials, to love biomimetic, to know that biomimetic is the alternative in dentistry. For minimal invasive dentistry, bioactive biomaterial works great, as the same as the SDF works great. The only problem is that if we are thinking to do it so close to the pulp, be so careful because maybe you can necrotic the pulp. To don't have this kind of problems, you can use it a bioactive glass. You can use it a strontium modified glass iomers, and you will have great results in effective dentin that you don't have with the regular glass iomers, and then you will not have this kind of results with a resin. And you right now know how it's work, this strontium bioactive glass iomer. So thank you so much for your attention. Celeste, are you here?
I am back again. Yes. Hi, Dr. Rocio.
Okay.
Fantastic. It was once again, I mean, what an amazing presentation. I'm literally, every time I hear this, I'm on the edge of my seat. So thank you so much for that. I had a look now in this section. I think we'll give it another second or so. If there's any questions, please, if you can, put it under the question section or even the chat section on the right-hand side. But I think your presentation was so thorough. You've answered all the questions. That was amazing. I think while we wait for some questions to come through, I'll talk through some of the, the launch special that we have. So I'm quickly going to
Yeah.
share my
You
screen.
can send me an email or maybe go to my page in Facebook, the Rocio Lazo Training Center, and you are so open to ask whatever you want about SDF or biomimetic materials.
Fantastic. Yes, I'll definitely, when we send out the certificates and so, we'll send on your contact details for the delegates as well. So thank you so much for that. The launch offer that we've got at the moment is if you buy one box of the Riva Light Cure, that can also be the high viscosity that Dr. Rocio referred to in her presentation, or the Riva Self Cure, whichever works better in your hands. That will then you'll then get the Riva Star at no charge. So the box of the Riva capsules will currently be selling for $2,499 on promotion, and then you'll get the Riva Star for free, which is valued at 2,000 Rand. So just to confirm, you'll see in the near future, the packaging will start to change on the Riva Light Cure and Riva Self Cure to highlight the iron glass, the biomimetic formula that's in there. But the stock that we currently have already consists of that biomimetic formula. So you're ready to start with the smart technique that Dr. Rocio presented tonight, as well as I'm happy to say that our Riva Star stock is also in, so we are all ready for you. Fantastic. Let's quickly have a look if there were some questions coming through. I think I'll start in the chat section. So Daniela is asking, how does the Riva high viscosity do in stress-bearing areas as to restoration?
What's the question said? Are the modified glass ionomers materials? I have here the chat. So I read, said, are there strontium modified glass ionomer materials that have silver in them, like Riva Silver, but with the strontium? Yes, yes, of course. The Riva Silver has strontium too. It's strontium, fluoride, ion, and silver, the three.
Perfect, perfect. Then I see there's another question just two above that, where Daniela is asking, how does the Riva high viscosity, how does it do in stress-bearing areas like a class 2 restoration?
You will have good results with class 2 restoration, because you will have in the high viscosity, this resists more the occlusion forces. So for this class 2 restoration will work perfect. I use it a lot in class 2. I show you many cases of class 2, and my option in this is the Riva Light Cure high viscosity. It's great. It's so fast. If you are working with kids, it's so fast to work. So that's give to you time, no? Because for kids, the time, it's so important.
Perfect, thank you. I've moved on to the question section, which is right next to the chat. If you want to go to that tab, I see there's a few questions coming through there as well. First one here, can you use the same as a Vita Bond as a base liner in adults with sensitive teeth after a deep filling?
Where's this question?
If you have a look on the right-hand side, you'll see the chat section at the top. Right next to that, there's the questions. If you click on there, then it will bring up the questions as well.
Notifications?
No, not notifications. No, it's in the white section on the side. It says
okay, here.
Chat, question, poll, and people. You should see on the side then. Otherwise, that's okay. I'll read the questions from what I can see on my side.
Okay.
I think what Chantal is asking is if you can use the Riva Star, the same as what you would use Vita Bond as a base liner underneath as a base liner in adults with sensitive teeth after deep fillings.
Yes, yes, it's great. The silver star, the SDF, is great for sensibility. Okay, so you can use it, and I think that your question it's about the SMART technique. Okay, that use this Riva star to control sensitive. For example, in the case of molar incisor hypomineralization with the Riva star, your control the hypersensibility in these cases, and then you are doing a good adhesion with the dentin, no? So it's better. So it's good if you are thinking in using SDF for like a layer, no, like a liner for control the hypersensibility. It's great. Yes, in molar incisor hypomineralization works perfect. Perfect. The problem is the color, no? It's a little staining, no? But if you use the Kai, you are not going to have these problems. And then applies a strontium modified glass iomer.
Perfect, thank you. Then I see Dr. McKenzie asks, does the SDF have a bad taste, especially if we use it in primarily in kids?
Yes, okay, all the SDF, the taste is not so good, for be honest. So how you can do it? First, use Vaseline, okay, cover, no, with butter, no. Sometimes you can find these chocolate butters, no, around the mouth, and then please use it cottons, no, for Iceland to be so sure that you are not going to apply the SDF in the tongue of the patient, because the taste is so bad. It's true, the taste is bad because the amino that it's inside, the taste is a little hard for kids, no. But if you tell to the kid to rice, you are not going to have the problems with the rice. So don't worry, rice if the patient tells to you that the taste is not good.
Okay, I think that's a very good tip. Thank you. A question again from Dr. McKenzie. Any tips on packing the HV Riva down in a cavity? I find it extremely sticky and pulls away from the base cavity.
Okay. You have what kind of Riva she had experience, the doctor had experience with this Riva high viscosity or
High
with
viscosity.
Riva high viscosity?
Yes,
Okay.
yes, high viscosity.
You when you apply, okay, you look the capsule. So in the top of the capsule, no, you need to press in the cavity, okay, and press there. It's touch the affected dentin, okay, and then push, no, to apply the material. So you're not going to have problem with the sticky of the material. Not. It's so good if you have time. You have like 5 minutes to work with this Riva Lightcure high viscosity. And you have the option of maybe the anatomy perfect in the occlusal surface, so you can you're not going to have problems, no. But pay so much attention when you apply, no, how you are applies the Riva high viscosity.
Perfect. Then another one on the Riva high viscosity. Is the Riva high viscosity very moisture sensitive? Does it do well with subgingival restorations when it is sometimes difficult to control bleeding And lastly, what intercastal width needs to be present in class 2 for restoration of the material?
Okay, it's asking like two questions. Can you yeah.
Let me ask them separately. So first
Yeah.
of all, is Riva high viscosity very moisture sensitive?
No, no. Remember that Riva, high viscosity, is the same. Has a strontium, has fluoride, and the difference is that you have resin. Okay, it's not only glass ionomer. You have resin. Okay, you are not going to have problems with the sensitive. Why? Because the strontium will remineralization, and if you remineralization the dentin, the dentin tubules, you will not have problems with the sensitive. So don't worry about sensitive in when you're thinking in use the Riva high viscosity. Yeah, Riva light cure.
So even in difficult situations where it's difficult to control the bleeding, the bonding will still work well in that case as
Yes,
well.
yes, yes.
Okay.
I show a case that I did a direct pull cupping, and if you look this case, the class 2, it's gingival, okay? And maybe you think that you are not going to have a good bonding there. Can I show again the
Yes,
case?
yes,
Yeah,
please.
I
We can share again, no problem.
okay here. Look this class 2 cavity. Can can you see the
Yes,
presentation?
yes, I can see the
Okay.
presentation.
Okay. Full presentation. Okay. Look here. This is bleeding. The gingival is bleeding. Look here. Okay. So
Mhm.
I applies in this case neo MTA, but here I remove the neo MTA and I restoration with the Riva light cure high viscosity. Look here, Riva light cure, and look the X-rays. Look here. This is infragingival, and look the perfect sealing. Look the sealing.
Yeah, that's
It's
very
perfect.
good. Mm.
Yes, so if you have problems with the bleeding, don't worry with the Riva light cure. It's not the same like you are working with a resin, okay? You will have control here. Look, perfect control, perfect sealing.
Fantastic. And then while we're on this, well, that's okay. We don't have to be on the presentation because the last part of the question is that intercuspal width. How much needs to be present in the class 2 for the retention of the material? So how much of that cusp in between do you need for it to have a good retention?
When you first use an MTA and then the Riva light cure, or when you are using only the
Yes.
Riva?
I think let's use both options in case they're not using the Neo MTA, which will also be launched with Wright Milner soon. So Neo MTA should be available in South Africa soon on your recommendation. So I think let's give them both options.
Yes, both options are great. For example, for direct pulp copying, for pulpotomy, or for necrotic. You can see these cases of necrotic that you can repair with the neo-MTA, no? And the problem of the neo-MTA is that it's not a definitely restoration. And the best restoration for a MTA is the glass ionomers. And you can use it both. You can use it self-cure, and you can use it the light cure, like a light cure high viscosity, okay? If you decide to use it, the self-cure, you have self-cure high viscosity too. Not only high viscosity in the light cure, you have in the self-cure and in the light cure. So in both, you have this option. So, okay, you only need to add the neo-MTA, like a little layer, like 2 millimeters, maybe 3, okay? And then you apply like a bulk fill of the Riva Light Cure High Viscosity or the Riva Self Cure High Viscosity. It's this kind of material, you use it in bulk fill form, that you can use it. You don't need to do it, okay, one little layer photopolymerization, another little layer photopolymerization. No, it's bulk fill. It's bulk fill, and you will have great results in photopolymerization. You are not going to have problems. It's for bulk fill.
Fantastic. I think that was very good having both those options. Then I think let's move on to another question. What can I use in 6-year-old with sensitive deciduous molar secondary to attrition? Sorry for mispronunciation there.
Yes, attrition. When maybe the kid is bruxism, or in this case, attrition. Okay, first you need to the treatment of this attrition. Okay, why it's happening. Okay, maybe sometimes you need to use like pearls for the treatment. Okay, and then you can maybe, if you want to have a better anatomic and control the sensitive, you use it a glass ionomer of high viscosity. In my suggestion in that case is light cure high viscosity. Okay, you can take all the webinar, and I talk a lot about the high viscosity, the light cure, because
that is your favorite one.
It's because I often use it, and I can tell to you that I have great results. All the cases that I show you, most of them I use it the high viscosity, the light cure high viscosity. Riva Light Cure, for me, it's perfect. For kids, it's great. It's great. You will love it when you start to use it. Sometimes I said, okay, I'm going to use it a resin, no, because it's a kerosene enamel. But I feel that it's more comfortable for me right now to use the Riva Light Cure for dentin and for enamel, because you have in both cases great results in enamel or in dentin, no? And for me, it's easier right now the Riva Light Cure than use a resin, no? Sometimes I take more time for the resin, and with Riva it's immediately. For example, if you are maybe using sedation for control the behavior of the patient, if the sedation, it will be with maybe nitrosamine oxide or general anesthesia. For this case, the time, you need to be so fast. And in the case of Riva, you don't need to do any adhesive system, no? In resin, yes, of course. First, you need to orthophosphoric in some cases, or if you want to use it, the universal adhesive, okay, but are more steps. With this, in one step, you don't need polyacrylic acid with the, listen well, with the Riva Light Cure. You don't need the polyacid, okay? Polyacrylic acid. But if you are using the self-cure, suggest that it's better to use the polyacrylic acid. Yes, so these both are different. No, that's the reason that I prefer the Riva Light Cure, because in one step I finish with the treatment.
So when in doubt, reach for your Riva Light Cure High Viscosity.
Yes, I love it. Aesthetic, well, you look the aesthetic. It's different, like another glass ionomers that sometimes said, okay, glass ionomers are great for remineralization, bioremineralization, but the aesthetic is not good. But look in the years, it's still the color, it's still the aesthetic of the material. Don't change in the time. Don't change. You look the follow-up, 24-month follow-up, and looks perfect. Looks at the same time, the treatment, the first day of the treatment. Yeah.
Fantastic. I think we've covered all the questions at the moment. There's some nice comments coming through. Thank you so much. It was very informative and helpful. Thank you so much. I've learned a lot. Very interesting lecture. Thank you. Excellent presentation. So thank you so much. It's been wonderful, as I was expecting it to be. So thank you, Dr. Rocio, for giving us your time. I know you're busy traveling at the moment, so you've been quite a busy little bee this, this last couple of days. So thank you, and thank you again to Michael, for sponsoring the event for us. Thank you to the Wright Milnes team, and again, thank you for our delegates for joining us tonight.
Thank you, Celeste. Thank you, Michael, for the invitation. I am so happy to be here, talking for South Africa. So I am so glad for this invitation. Thank you so much. Thank you so much.
Hopefully we can get you here sooner rather than later to come and do an official presentation for us. Thank you, Dr.
I hope. Thank you. Bye-bye.
Good night, everyone. Bye.
Good night. Bye.
Bye.